On my topic today, I'm going to talk about the VA ECMO, I'll give you an overview about that. But it's going to start with that's my disclosure slide, with one of the slides here I would like to present just to see the idea and where the origin of the concept. Galois in 1812, he was thinking about if you got now a replace the heart and perfuse organs with blood, this organs would be able to live an indefinite period of time, which is the concept we're doing with mechanical circulatory support. What is the option or problem with that, with the mechanical circulatory support when we replacing the heart or replacing the heart and lung, is the hemocompatibility. We are not replacing the heart with something hemocompatible like what the nature is doing. But it's still a lot of work to be done, but the concept is working. And just to give you a short few slides about the history of ECMO, and you see that the concept is very old and nothing. It's not new. You see that the first direct contact artificial oxygenation of blood in extracorporeal circulation, they show defibrinated blood with air in a balloon. And Schroeder in 1882 developed a three-dimensional direct contact bubble oxygenator to perfuse isolated kidneys. And Frey and Gruber in Leipzig in Germany first use of two-dimensional direct contact extracorporeal oxygenator that exposed a thin film of blood to air in an inclined cylinder. And later on, with the discovery of heparin, which opens the way for many artificial devices. It was in 1916, and then in 1930, John Gibbon invented the freestanding roller pump for ECLS, and in 1953, that's the first successful use of extracorporeal circulation in a cardiac surgery. And many of you, if you are going to visit Philadelphia and go to Thomas Jefferson University, they have a corridor there named after the name of Gibbon, and they had this machine there. And in 1970, Donald Hill in California, in San Francisco, for the first time applied the extracorporeal circulation in patients struggled from severe ARDS and was successful. Well, and all of us knows Bartlett and his story with this young lady, Esperanza, and we put her in extracorporeal circulation for a few days and recovered, and she is now 21 years living after this procedure. But when we talk about ECMO, we should talk about four main components. That's we need a pump, we need an oxygenator, we need tubing, we need access. That's the main component. Without this, one of these components, there is no ECMO circuit. That's the basic foundation, basic requirement for every ECMO circuit. That's here, there's many clinical devices many devices in clinical use. We have in Integris Baptist Medical Centers, 3 of those. That's the Spectrum, that's in the you see that's this device here down to the right. Still we are negotiating with them to get that device to Integris. The other 3 devices are in clinical use. All of them are applying maglev technology for the pump, which have a lot of advantage, and I'm going to talk about that later. The access. I'm trying to focus today about percutaneously applied via ECMO, not about the central ECMO. We are using FIM approach, and we're using the from Medtronic and Mackay, the cannula, usually using an arterial side 15 to 19 and a venous side 15 to 25 French cannula to drain blood from the right side of the heart, and arterial cannula to return the blood back to the iliofemoral artery. And all of them are coated. That does not require a lot of dose of heparin when you're running them on a patient. Also important to add that in one of the major problems we had in the past was the lower limb ischemia when we were running FIM ECMO. In every patient before accepting ECPR, in every patient we're applying or thinking about ECMO on them, we try to get the lower limb perfusion catheter before cannulating the big or placing the big cannula in a femoral artery. And what we're using is using from Arrow wire reinforced cannula, which is different than what some of us having in the cath lab from the Japanese company. I don't remember their name now, because this cannula does not kink because of the wire reinforcement. The other cannula kinks after 1 or 2 days of support, and you see that despite the fact that you have the cannula in a patient, but you have lower limb ischemia because there's no flow in the cannula. And the circuit is important because if you look to the left side of the slide and the right side of the slide, in the past, we did not focus only on these 4 components of the ECMO. We added bladders, we added pre and after oxygenator, the blood pressure measurements, we added connectors, we added sometimes connector to add to connect the CRRT to the circuit, was make the circuit very complex and need a village of people to manage only the circuit not the patient. If you look to the right side of the slide, when we now modified the circuit to be simplified, we got rid of most of the connectors, we got rid of the pressure sensors, not sensors, the pressure connectors, and simplified that, which added very big important point for us. We're talking about the hemocompatibility, and every part in a circuit will add to or to increase the shear stress and add to problems might happen to the patient down the road. And when you look to this review article and see how much change is happening and how we are, when you apply extracorporeal circulation to the patient, that every blood cell will be activated. If that's still the true, we wouldn't be able to manage patients with ECMO. It's true if you have a patient like me here and you're going to support me with extracorporeal circulation, I hope my inflammatory markers are low, and if you're going to put extracorporeal circulation on me now, we're going to increase my inflammatory marker. But if you have a patient in advanced cardiogenic shock, multiple pressors, inotropes, his heart inflammatory marker is high to the roof. And if you add ECMO or any circulatory support system to them, you don't want to increase that. You want to eliminate the cytokines. You don't want to add insult to already existing problem to the patient. That you have to pay attention to the hemocompatibility and to add devices which would help you to eliminate them and lower them to achieve the success, because you want to reverse the multi-system organ dysfunction which has started to happen. That's why we have to pay attention to that. And just here as an example to see what different parts from the circle and how much they can add to the shear stress on those patients. If you look to the cannula and changing the cannula size from and the same cannula, changing the flow from 4 to 6 liters, increasing your shear stress from 465 dynes to 1100 or more than 1100. And if you look to the right side of the slide, showing you which shear power you need to activate different cells, blood cells. If you see that you need only 75 dynes to activate the leukocytes, more than 100 to activate the platelets, and more than 2,000 to rupture the RBC. That here I'm trying to show you that to see everything is going to lower your shear stress, and the circuit is appreciated because we don't want to activate those cells. Other example here from the oxygenator, when you see that different oxygenator ion and how much change in a platelets, white blood cells, and neutrophils from the baseline when you apply those oxygenators for a couple of hours. Only a couple of hours. We're talking about ECMO. We're keeping the patient days. We're keeping the patient weeks on ECMO. That's why important to look to this point. Well, if you see that here in the past, we were using complex ECMO here, again, needs a village to manage that. When we simplified, now we can, even with trained nurses, to manage the circuit at the bedside and no need to have 24/7 perfusionists to sit beside the patient because the circuit does not need that. And what we're talking about now is the new generation ECMO circuits utilizing the maglev technology. And maglev technology is compared to the other technologies we used in the past, is having less shear stress, less activation of platelets, and might help us also lowering the level of anticoagulation we're giving those patients. And also low resistance, low pressure drop oxygenators, again, helping us to improve the hemocompatibility of the circuit. And we used heparin-coated systems, just also helping us to lower the level of anticoagulation. And in some cases, we have to stop the anticoagulation because of bleeding complication, and we don't want to have a circuit. When I stop heparin, I'm going to give to punish the patient in 2 hours with clots. That we would like to have circuits which giving us certain period of time to run them without any anticoagulation. We have that. We have 25% of our patients, we're running them for period longer than 48 hours without heparin, with very good results. And also the percutaneous cannulation, we don't need to have cut down and also rescue bleeding and other complications. And nearly no side ports. Again, we don't like to add any ports or any connectors to the circuit to lower the shear stress. Well, it's also percutaneously done. You see that how we're doing that at the bedside, that we're getting that here, the antegrade cannula first. That's and then cannulating for the big cannula and putting the cannula and going to the other side, cannulating the vein and getting the circuit at the bedside, connecting that in appropriate way, and start with the support. And you see here the difference in the color reflecting the venous and arterial side. And you see that the angiogram here we're doing at the bedside to be sure that the cannula in the right position and not in a vein here, like in this case. Even that case was not done by our team, it's done by outside team, and there was the vein was cannulated, and you see here that because of the valve at that site was the wrong spot. Well, now when we're talking about ECMO, and I have a patient now, we need an ECMO, we have to think about 5 cardinals and basic elements. The first one to talk about the indications and contraindication. What kind of patients might require or needs the ECMO support or does need the ECMO support? And that's here the indications, and many conditions might, when you see them in a patient, the patient might benefit from ECMO. That patient was refractory cardiogenic shock, secondary to acute MI shock, acute on top of chronic heart failure, fulminant myocarditis, massive pulmonary embolism, arrhythmias, post-cardiotomy cardiogenic shock, and so on and so on. And there's, in the right side of the slide, you see that's the relative and absolute contraindications. The absolute contraindication is that the most important for us if the patient does not have DNR, DNI orders. That's important. So that's okay. If we have that, that's no, don't touch. And also incorrectable conditions, unwitnessed arrest, and if we don't have exit strategy for the patient. That's important to be discussed. There's some relative contraindication like uncontrollable bleeding, dissection, some severe AI, that's something we have to discuss case by case and see it's worth it to do or not to do the case. From our experience in Integris, as you see that here we have about 71% from our patients supported with ECMO was related either to acute MI shock or acute on top of chronic heart failure. That's the blue part from the circle. If you look, we have about 29% from our cases have different etiology, and we shouldn't forget about them. That's unfortunate literature. Those patients are underappreciated in literature. There's not too many things published on them. And also I would like to underline here, compared to other, we have significant number of patients who got that in a septic cardiomyopathy setting. Patient in severe sepsis and septic shock and the heart start to struggle from that, and in multiple pressures and inotropes, that patient are benefiting from the VE ECMO, and we have significant number of patients on this category and with good success. Well, the second thing you have to think about is the cannulation strategy now. If you have a patient, and it's the first thing, I have to look to the indication, contraindication. The second, I have to think, okay, how am I going to cannulate this patient, like we discussed today about patient in post-cardiotomy cardiogenic shock, how we are going to cannulate him, central versus peripheral, or or is going to be axillary, fem-fem. That's many ways how to cannulate the ECMO. We prefer to go for the fem-fem bypass because our team is not surgeons, and we train them to do the fem-fem and work with very good success rate. But if you are in the operating room, you have certainly the option to do central versus venous cannulation. The central cannulation, you have a big cannula, you're getting to have more flow. That certainly is advantage compared to the peripheral cannulation. However, you are going to have the risk of bleeding and risk of infection is certainly higher than the peripheral cannulation. The peripheral cannulation, you have the advantage, could be done at any place, could be done here in this room, practically speaking. It could be done at the bedside and then be used for ECMO retrieval, which is also important because we would like also to open the access to other patients and not in hub centers. Well, also, before I'm going to discuss the unloading, because I'm not going to have many slides in unloading because I know that Dr. Abraham is going to discuss that. But when we talk about that, the 45 cardinal issues we have to discuss is the lower limb perfusion. I'm starting now to go with have the big axis. I would like to go to the SFA and try to cannulate that. We target the SFA and not the profunda. SFA is going to give, if I mistakenly cannulated the profunda, we keep it in the patient and monitor the lower limb ischemia. If we're going to have ischemia, we are trying to reposition the cannula in the right spot. And again, we are recommending to do an arteriogram at the bedside to also confirm the position of your antegrade cannula, as you see here in the left side is in an SFA and the right side is in the profunda. And how we are monitoring now the lower limb ischemia, we are putting that NIRS, that's the to monitor the lower limb ischemia. We put the paddles from this device in right and left side. That means any cannulated side and the non-cannulated side. And usually we don't want to see difference for more than 25% between both. If it's increased, that's alarming signal. That not means we have to do something, but we have to watch it more carefully, and also training our nurses to do also in hourly looking to the peripheral pulse and document that. Well, regarding the unloading, when I have a patient now on ECMO, I have to think this ECMO would be enough or I have to do something more to unload the left ventricle, because one of the major problems you might have after placing patient on ECMO, that if the heart is not, you will not be unloading the heart in a satisfactory way, and the heart will be distended, and you will have pulmonary edema and so on. That's something you have to think within 2 or 3 hours after placing the patient to ECMO to see how you're going to do that. It's still debatable in between the experts to see if every patient should be unloaded if you have a patient on ECMO, or you should do that in a selective way. In our cases in Integris, we do that in a selective way. How we're doing it, because every patient is going to get SWAN, and every patient we're trying to keep the aortic valve to open, to have a significant ejection. And if you see that case here, which is a 48-year-old male, was admitted to outside hospital with acute MI shock, secondary to late presentation of STEMI. He went to the cath lab, he got 2 drug-eluted stents, and Impella CP was placed. Patient remained in cardiogenic shock despite the Impella support, and required intubation, and lactic acid was 10. Subsequently, patient was transferred to our institution for further management. He was placed on ECMO, and you see the monitor here now. After, because of the Impella that hemolyzed, we removed the Impella, and the patient was on VA ECMO. If you look to his VA, the PA pressure here, and the aortic valve opening, and you have a PA pressure 14 to 10, and mean pressure of 11, who would start to unload this patient? What I'm going to achieve more from the hemodynamic standpoint? If I'm achieving that with one device, why should I add something to that? That's why we try to do that in a selective way. We put SWAN on a patient, we try to get the pulmonary artery and diastolic pressure below 18, and aortic valve to open, and monitor also with echo the LV distension. If we wouldn't be able to achieve that within a few hours, we are going to escalate with Impella or whatsoever to unload the left ventricle. But we are going to hear more about that in the next presentation. Well, what about the exit strategy now? Our goal for every patient coming for temporary mechanical circulatory support, we try also to help the heart to recover. That's our first goal. However, some patients, the heart will not recover because it's an acute and chronic heart failure, and the likelihood of recovery is not high. We might consider some of those patients for durable mechanical circulatory support devices, or might be considered for heart transplantation. Or in few cases now, and if, unfortunately, if you have that patient, you put him on ECMO or temporary mechanical circulatory support, he struggled, complication, and started to have brain death. Some of those patients, we have some collateral benefit from them. We might use their organs for organ donation, which is something we were not able to help this patient, but we might be able to help some other patient with his organ. And we have a couple of our ECMO patients went for the organ share organization and utilize the kidneys or liver or some other organs from them. And something we have also to think about. Well, it's a very busy slide here, and trying to simplify that in the next slide to see what is when we put patient on ECMO, what we are doing. The first couple of days, because the ECMO, when I place the patient on ECMO to restore the circulation. I would like to bring the blood pressure back. I would like to reduce the high doses of inotropes the patient was getting. I would like to see that the patient after 2 or 3 days of all inotropes, blood pressure is okay. And I started to see that the organ started to recover. That means within the first 48 hours, I would like to have that the trend now. The patient is starting to improve, lactic acid is going down, and blood pressure is improving despite the reduction of pressures. and the LV is well unloading to help the left ventricle to recover. The next couple of days, I would like to look, most of this patient coming to us have high volume overload. Would like to get those patients now back to euvolemic status. Spend from day 2 to day 7 to get them to that level, either with diuretics, because if I'm restoring the circulation in an appropriate way, the kidney will function, might need some diuretics to get the fluids overload under control. If it's not going to happen, we are more also proactive in applying CRRT to those patients to get the volume overload down. And also enhancing myocardial recovery. Everything might harm the heart, we're trying to prevent it too. That means oxygenation should be okay, blood gases should be okay, electrolytes should be okay, thus to give medium for the heart and optimize the likelihood of the heart to recover, including the unloading and watching everything you are doing, and also helping the end organs to recover. Either many of those patients coming with transaminitis and some shock liver, shock kidney, and even some gastrointestinal problem. We have to manage that and to help the patient and to help the process of weaning. If we achieve that, we're going now to look, that's the time to think about weaning from ECMO or weaning from the mechanical circulatory support. How we are going to wean that, we have our weaning protocol. I think I have that here. I'm going to, my next presentation, I'm going to talk about the weaning protocol more, but we're going to start with the weaning process. That means with echo, we're doing echo every day or every other day on those patients to look to the trend. How is LV function is improving? And if we achieved certain criteria now, that means the patient is euvolemic, his organs are recovering, have lowest level of inotropic support defined by 0.5 mics of epinephrine or lower, and blood pressure above 65, we're going to apply the weaning protocol. If the patient fulfills the criteria for weaning, we're going to schedule him for to go to the OR to go for ECMO decannulation. ECMO decannulation, we're doing that in OR. That means we're implanting that at the bedside, but decannulation we do that in OR to repair the vessel, because that's a big cannula staying longer period of time in a patient. We prefer to do that in the operating room. If now the patient is not weanable, that within this period of time, we are, as a multidisciplinary team, we are going to, during this period of time, we're going to see if the patient now qualified for advanced heart failure treatment or not. We have, by day 14, we have to have a decision about that to say, is the patient a candidate or not a candidate? If he's a candidate, we are going to accept him and to try to schedule him for the procedure. If we're not, we are going to prepare the family for end of life decision, how we are doing that. Some other issues I would like to put your attention to if you're putting patient on ECMO, some other problem might happen. It's as in the first things you have to think about when you put patient on peripheral ECMO, the Harlequin syndrome or the north-south syndrome when you have, because if you have two kind of circulations, if you are applying ECMO in a patient with a little bit strong heart and bad lung. In such kind of cases, you're going to have two circulations, the ECMO circulation and the native circulation coming from the heart. And if you have a bad lung, the blood coming from the heart will have less saturated blood and might lead to ischemia to the upper body half. That's why we are recommending in all patients, we are placing them on VIA ECMO to monitor your blood gases from the right radial artery. If the blood gases from the right radial artery have a saturation of more than 90%, you are okay, because the brain will be okay and your brain will be okay and you have enough support. Other complications you have to take care of it is the and you have to be aware about that: bleeding, thromboembolic events, limb ischemia, LV distension, hemolysis, circuit malfunction, oxygenator failure, cannula dislodgement, and some picture here showing that the clots in oxygenator. And you see that some also important to mention, if you don't have the aortic valve is not opening, you might see clots in aortic valve root here, as you see that we have. That's why how important is the echo to be done. Also in some cases with PFO, we watched that our cannula from immigrated from the right atrium to the left atrium. In such kind of case was a welcome complication because it's unloaded the left side of the heart as well, but you have to to be aware of it. That's here. The slide represents our complications. It's published, our publication we published in the Annals of Thoracic Surgery 2019. Look to all our complications, we compare that to the literature, and we are proud that in almost every category we have less complications compared to what's published. And that's here, I think one of my last slides, because it started to ambulate. It's important now to ambulate this patient, and even with VA ECMO, that you see that left side part of the slide here, one of our patients with VA ECMO start to exercise on a standing bed because we cannot keep the patient all this period of time while he's waiting for heart transplant or waiting for VAD or even waiting for recovery. We started to exercise them, and they might be able to do few steps outside the bed, but not more. In the other case here, the patient with VV ECMO, which was able to walk because we had different story than the VA ECMO. That's those patients, we are ambulating them. They can walk because we are cannulating them from the neck, and they are able to stand up and to walk in it. Last slide here, I would like to underline how important the team is. Without having a team are available 24/7, and when I talk about the team, it's not only the ECMO team, it's ECMO teams, it's in the APPs, nursing, multidisciplinary MD teams, because we don't have support from interventional cardiologists, heart failure cardiologists, CT surgeons, infectious disease, palliative care, all that we need them to manage those patients. They are very complex cases, and no one team alone will be able to achieve success and manage those patients alone. We have to have captain in a ship, that's important, but we need all that disciplines together to be able to deliver. That's my last slide. I would like to stop here, and if you have any question, more than happy to take them.